Thank you for Chairman introduction. Especially I appreciate Dr. Tio's invitation. It is my great honor to have this opportunity to share our recent research work here. The topic I want to talk today is Talaromycosis, a leading cause of death in patients with advanced HIV/AIDS disease in southern China. First of all, I introduce the background. Talaromycosis manifest, for short TM, formerly called as penicillin manifest, was discovered in 1956, and it can cause a systemic infection with fever and anemia similar to designated cryptococcosis. And the TM is a very special fungus that exists temperature-dependent dimorphic. TM epidemic is higher related to HIV/AIDS epidemic. Before 1980, TM infection was rarely found. However, in the past 40 years, TM infection increased rapidly along with the prevalence of HIV/AIDS. And TM is an opportunistic infection of HIV patients. Our studies show that about 90% cases were found in Southeast Asia and Southern China. In China, about 85% of reported cases come from Guangxi, Guangdong, Yunnan province, were located in southern China. We also found that 288,000 cases has been reported in 33 countries to the end of 2018, with an estimated 7,300 cases and 400,900 deaths each year. The global Talaromycosis incidence is projected to increase by 35% by 2025 due to the rising incidence of AIDS in China. We also found that Guangxi has the highest number of reported TM cases, accounting for 43% case in China. In Guangxi, about 16% of HIV infected patients were infected with TM. Thus, TM is still one of the leading cause of death for AIDS patients. The mortality of TM infection ranges from 16.7% to 33% in other countries and regions. However, there is no data about the mortality of TM infection in Guangxi, China. Therefore, we want to address two issues. First, effects of TM infection on mortality of HIV/AIDS patients. Second, machine learning based in hospital mortality prediction of HIV/AIDS patients with TM infection in Guangxi, China. In the part one, our study focused on effects of TM infection on mortality of HIV/AIDS patients. So we conduct a retrospective cohort study, compared 4 years data. Totally 6,791 patients were enrolled, including 1,093 patients with TM and 5,698 patients without TM. These patients were then divided into different groups and compared the mortality. This is the general characteristic of our subjects. Here show several characteristics is this significant difference, such as age, gender, CD4 T cell count, etc. This figure shows the proportion of AIDS-associated complications. We have found that TM ranks fourth with the proportion of 16.1%, following PCP, TB, Candida, the top 3 complications. However, for the mortality, TM reached top 1 with 13.9%, even higher than PCP, TB, Candida. In other words, in Guangxi, TM is the leading cause of AIDS deaths. The molecular of TM group, 70.5%, was about 2-fold higher than that of non-TM group. For mortality density, similar results was observed. We also compared the cumulative mortality between TN groups and non-TN group. The results show that either among all patients or among patients without other complications, the cumulative mortality of TN group was significantly higher than that of non-TN group. Since many characteristics exist different a significant difference above. We will use several statistical analyses to exclude the effects of confounding factors, include cost model, subgroup analysis, and so on. Firstly, cost model analysis showed that the adjusted HR of TM was 1.8 with p-value lower than 0.001. So the results shows that TM still a significant risk factor for HIV deaths after adjusting all possible factors. The subgroup analysis focus on the effect of TM infection on mortality of patients with other common HIV-related complications, including TB, pneumonia, candida, and so on. The results show that TM infection significantly increase the mortality of HIV/AIDS patients with these complications. And this is the statistical analysis on ART, CD4 T cell count. The two node factors that influence AIDS deaths. The results show that TM infection increased the mortality of HIV/AIDS patients, regardless of demographic characteristics, CD4 T cell count, and other disease. Especially, TM infection was a greater risk factor for death of HIV/AIDS patients with other CD4 T cell count. Finally, we use propensity score matching to confirm our results. After PSM, we got 346 matches. The results show that the AHR was 4.52, even higher than the AHR of 1.8 before PSM. Therefore, we got two conclusions. First, TM infection is commonly found in hospitalized HIV/AIDS patients in southern China. Second, TM infection was associated with a higher mortality rate than most HIV/AIDS associated complications. This research have been published online in CMI. In the part 2, I would like to talk about machine learning based in hospital mortality prediction of HIV/AIDS patients with TM infection in Guangxi, China. The factors that influence in hospital deaths of HIV/AIDS patients with TM infection are not completely clear. Machine learning techniques can be used to develop a prediction model to identify the relevant prognostic factors to predict deaths and appears to be essential to reduction in hospital mortality. Thus, we intend to use machine learning technology to solve the above problems. Here, show the technique route. First step, data collection, including demographic, clinical complications and symptoms, and laboratory methods. Second step, data cleaning. Totally 1,927 were enrolled, including 1,671 survived and 927 died patients. Third step, feature selection. Filter out important independent values through the features engineering. Four steps, model construction and validation. For machine learning model use to build a model, including SDV, BOAST, SVM, logistic regulations, and KMM. Finally, model comparison. Find the best model. This is the general characteristic of study subjects, such as age, gender, BMT, occupations, ART, etc. In filter selection, a total of 39 clinical features were collected. Feature univariable analysis, correlation methods were used to select the significant features. Finally, 15 features used to build a model. Here, the figure shows the 15 features used to build a model. And we have found 3 significant features were important, include ASL, ALT ratio, septic shock, respiratory vector. They has higher contribution to the model. This is the performance evaluation of 4 machine learning models at the training set and at the testing set. This is the performance evaluation of 4 machine learning models at training set and at the testing set. Here the figures show the 4 prediction models constructed based on the 15 important variables had different predictive performance. And the XGBoost model was the best model. Therefore, we got 3 conclusions. Firstly, the AST-ALT ratio, septic shock, and respiratory failure may be the important features that influence in hospital deaths of HIV/AIDS patients with TM infection. Secondly, XGBoost machine learning model is a good predictor in the hospitalization outcome of HIV/AIDS patients with TM infection. Thirdly, the model may have potential application in mortality prediction and high-risk factor identification in the Talaromycosis population. And these results have been published in PMTD. Despite the use of antifungal treatment among nearly all TM infection patients, the mortality among TM infected patients is still relatively higher. So we need to try some methods to control TN infection, including early diagnosis, early treatment, and so on. These above results highlight the need for the improvement of TN diagnosis, diagnostic treatment, and prevention among HIV/AIDS patients in southern China. The machine learning model may have potential application in TM prognosis and diagnosis. Finally, I appreciate Dr. Hao Liang from Duke University. She gave our team a great help and made a good cooperation. I also want to thank our cooperators from Guangxi Both People's Hospital. Finally, I would like to thank my colleagues, Professor Ye, Professor Jiang, and Dr. Wei. That's all. Thanks for your attention.